Hi, good afternoon, everyone. Thank you for joining us today. I'm Andrea Bonacci, Director of Population Health Programs with Adirondack Health Institute. Welcome to the 2021 North Country Leadership Summit, emerging from a year of change and opportunity to rebuild and reimagine. The summit is being brought to you by Adirondack Health Institute and Fort Drum Regional Health Planning Organization. I would like to thank our sponsors who supported today's summit and made it possible today. And just a few housekeeping items before we get started. Just a reminder that we are continuing to hold summit sessions through the end of the day tomorrow. So we have sessions at 10, 12, and 2 o'clock. Please remember to place all of your questions and comments in the chat, and our staff will ensure that your questions are answered during the Q&A session at the end of the presentation. A reminder that all attendees will remain muted with their videos off during the presentations to ensure best broadband connectivity. And all presentations will be recorded and archived on the North Country Leadership Summit webpage by October 1st. So we have a great presentation up next. So I will hand it over to Joanna Loomis and Dr. Stephen Lyndaker to present translating transitional care management to the Medicaid population. So if you'd like to introduce yourselves and get started, please take it away.
Awesome. Thank you so much. I just want to make sure you can see my screen.
Yes, you're good.
Perfect. So I'm Joanna Loomis, and actually I'll go ahead to the next slide where we kind of talk through who we are. I'm Deputy Director of North Country Initiative, and we're located in Watertown, but we serve Jefferson, Lewis, and St. Lawrence counties. North Country Initiative is essentially, it's a clinically integrated network, and it previously served as our region's DISREP PPS. And we are complemented by our partner organization, which is Fort Drum Regional Health Planning Organization, which is a nonprofit really focusing on population health initiatives. We have a shared staffing structure, so we have a lot of different focus areas from population health in and of itself, behavioral health and wellness, workforce, telehealth, fiber, you name it. So North Country Initiative also operates an ACO and an IPA, which I'll get into in a moment. But that's a little bit about me. I'm born and raised in the North Country, and I'm joined today by Dr. Stephen Lyndaker. And Steve, I'll let you introduce yourself.
Great, thank you. Yeah, my name's Steve Lyndaker. I'm a internist in private practice. I've practiced general internal medicine for 27 years, hard to believe. And I've been medical director for FDR HPO for the last decade, and happy to be here and participating. Thank you.
Thanks, Steve. So again, just a little bit about us. We serve primarily the 3 counties. Again, we're a former PPS for DISREP. North Country Initiative also operates an accountable care organization where we have a Medicare shared savings program level 1 contract. We've had that since 2015. We also operate an independent practice association, which can contract with any other payers. We currently have 2 value-based arrangements in the Medicaid space, and that's 2 level 1 contracts with regional managed Medicaid care organizations. So been working in the value-based arrangement space for a bit now, but certainly always learning. And this pilot project is definitely a strategy that came to our mind to help impact our Medicaid population. We have over 80 partners, and that includes, partners across those 3 counties, clinical, community-based organizations, government organizations, and together our 3 contracts cover 20,000 lives in the region. So we can talk a little bit about, what is this that we're talking about today? This is really a pilot project that NCI has embarked on. We We started this in April of this year, so it's still rather fresh, and we're still doing it, and we're still learning, and we're going to be learning for quite some time. But it really comes down to this idea of transitional care management. And you are going to see us use two terms. One is TCM, which is transitional care management, and it really refers to traditional TCM, which is something that's actually billable under Medicare. And then what we are doing is trying to apply that principle to the Medicaid population. And that's where mTCM comes in. And I always have to note that's a Dr. Lyndaker copyright pending term. So he came up with that. So we could probably start with what is TCM. Some of you on the call may be familiar with TCM, very familiar with it. Others might not be. So just to level set, just for any that aren't super familiar with TCM, it's really for patients who have been discharged from an inpatient setting, basically hospitals, but also skilled nursing facilities or observation status. When they get discharged to their home or community setting, then we know that can be a very vulnerable time for a patient. You just had an inpatient stay, so something's going on, obviously, and maybe you're leaving the hospital with different or vastly different medications or more medications than what you came in on. You may have a whole bunch of, a big discharge summary packet with things that you need to do now. Maybe your diet needs to change. Maybe you need, certain durable medical equipment. Maybe you need to follow up with certain providers. And it can be a very vulnerable time. And not surprisingly, that time following a discharge is one where you tend to see a lot of readmissions. So things can go wrong and you can land back in the hospital. So what TCM does is it is a vehicle in Medicare through which healthcare providers, and it's usually the primary care team, can reach out to their patient who was just discharged and engage them in services in the days and weeks after the discharge. Really, it centers around the 14 days after they're discharged. And we talk about it a lot in our ACO because it is reimbursed by Medicare, but it's also, I would say, nearly universally reimbursed by Medicare Advantage plans, as well as many commercial plans. And so what does that traditional TCM look like? Here's a sort of a very simple flow chart. Dr. Lyndaker, I don't know if you wanted to sort of walk us through what TCM looks like in a practice setting.
Sure. Took me a minute to find my mute button. Sorry. So this is a fairly straightforward schematic. I wish it were this easy. So our office has hospital discharges from between 6 and 8 different hospitals. And we start tracking people really at the time of admission. And it's kind of a group effort with all of the front office and certainly nursing staff. And we then develop kind of a spreadsheet of sorts that we're a tracker for those folks as they're in the hospital to make sure that the day of discharge we know, and then we can start the process that includes the phone call. And that's probably the single most important piece of this, I think, is that initial call, contact, reconciliation, and then making sure that little problems stay little problems. I would say, maybe about a third of the time there needs to be clarification, even right then, about something that either family members of the patient has a concern about. And that often is just, it can be housekeeping things, or it can be fairly substantive treatment issues. And then probably the next thing is getting the data and information to the right person at the right time. So we spend a fair amount of time making sure that we have all needed information for that follow-up visit. And the 7 to 10 days is really, in order to have a high complexity visit, it needs to be done in 7 days. But you can have a moderate complexity done at day 5 as well, but it's still a moderate complexity. So it really is based on the complexity of the care. I got to say, most of the discharges, quite honestly, nowadays are fall into the high complexity. It's just the way medicine has evolved. And so I think there's a fair amount of vigilance on the front end staff. From a provider standpoint, this has been wonderful because we are informed early, we're involved in the process, we get good information, and things for the most part are organized when they're coming in for their post-hospitalization visit. So we're really, it's quite efficient in terms of, again, the provider side of things. And it allows us, I think, to be a little more proactive earlier in the course of that transition, and to some extent work as a little bit of guardrails for the patient who we typically know quite well. So I think the provider feedback that we get is almost entirely uniformly positive. And then the payment also is a little more robust in terms of Medicare reimbursement, and I think that reflects, the increased, vigilance and detailed work that gets done prior to the visit and during the visit. And then lastly, I think our ACO has, benefited considerably in terms of better care and you're good, Joanna, that better care and reduce costs. And so that's really been, I think, probably our most successful initiative that we've done, but also I think our most well received really by virtually everyone. Certainly patients and providers. Staff sometimes get, it can be a little arduous. But still, I think in the long run, everyone understands there's just an obvious benefit of doing this on a regular basis, and we've really tried to capture at least 75% of those discharges if possible. And it would seem like it's a simple process, but really it does take a lot of iterations to get it down to high efficiency.
Yeah, thanks for that perspective and the insight into how it looks, from a practice standpoint. And I would echo that, you can see on the screen our ACO's TCM journey, so to speak. Back in 2017, this was not something that really we were focusing on in a systematic way. And then we got behind it, and you can see how the numbers have improved over the years. Our goal is 75% of our eligible discharges should get a TCM. We're obviously not there yet, but we're moving in the right direction. And you can see also just the black and white kind of results of what transitional care management has in terms of the ACO's perspective. Significantly lower 90-day post-discharge readmission rates, and with that, incredibly lower 90-day post-discharge total cost of care for patients with discharges who got a TCM versus those who did not. So definitely a win-win-win for everyone involved. So that brings us to mTCM. The premise for this is the fact that Medicaid, unfortunately, does not reimburse for a similar service. So, when we started getting into the Medicaid value-based space, we knew how well TCM works in our Medicare contract, but how are we going to approximate this and carry those lessons learned into our Medicaid population, who they're vulnerable, right? If you think about a patient population that if they have an inpatient event and they're leaving with a discharge packet and a whole bunch of things that they've got to do, arguably, what population is most vulnerable in that space of time, it's probably going to be your Medicaid population, which, generally speaking, is going to have some barriers, potentially in terms of health literacy, transportation to get the things that they need, support systems to be able to help them through this time. So we knew we had to do something around transitional care management for Medicaid, but how can we do that if Medicaid isn't really reimbursing in a fair manner for such services? We also took a look at the Medicaid population and some considerations that really affect them, potentially more than just the Medicare population. We know that Medicaid has overall a higher intersection with the ED. And so, yes, there's inpatient stays among Medicaid patients, but there's definitely a pretty high ED interaction rate as well. Obviously, social determinants of health. So getting at a little bit that I just shared, the concerns about health literacy, transportation, food, etc. And we also know that the Medicaid population has a fairly low engagement with primary care. And also they're kind of tough to get a hold of sometimes. They tend to have phone numbers that change frequently. They tend to have addresses that change frequently. And I don't mean to generalize the population, but that is just sort of a general pattern that we know among that population. So NCI had some funding left over from DSRIP, and we wanted to put it to good use for the Medicaid population by funding a pilot that pays our partners to do a TCM for the Medicaid population. So it's self-funded. It runs from April of this year through December of this year, although we are investigating options and ways to continue it out because we know that 9 months is not going to be enough. But the things that you see in blue on the screen are kind of the tweaks that we made from the traditional Medicare TCM model. So again, given the ED interaction, we opened it up and said that our partners can do an mTCM when a patient not only has a hospital stay, but if they have an ED stay, we would allow an mTCM. The Medicare TCM requires that you have an initial contact with the patient within 2 days. We lengthened that to 4 days, just again, knowing the contact challenges sometimes faced with this population. In Medicare, you can have that second contact be an in-office face-to-face visit or an audiovisual connection. That was the case pre-COVID, and that continues to be the case now. But we also opened it up to be a phone call only, with the guidance to our partners that the phone call shouldn't be a default option. We would like the face-to-face component. So if they can do it in office or through an audio-visual connection, that is the preferred method. But if the patient has limitations to doing either of those things, then we are okay with them doing that second contact through phone call. And then the big piece that we added was around social determinants of health. So for years now, we've been talking about SDH. We've been trying to figure out, and we've incorporated SDH in many ways and, in many projects, but really tackling head on, how are we going to start screening in a standardized fashion for SDH needs? And we just hadn't quite gotten there yet. And this we felt would be our foray into that world. So we adapted a standardized SDH screening tool from the American Academy of Family Physicians. And we adopted that to be our NCI screening tool. And we're asking every partner that does an mTCM service to screen using this tool, to code Z codes that we've sort of given them a body of Z codes. And some of you on the call are very familiar with Z codes, and some of you may not be. We'll kind of get into that a little bit later. And then to refer accordingly. So we developed a very simple, low-tech inventory of area community-based organizations that would meet the needs that are identified in this screening tool. And we want our partners to conduct a closed loop referral to that. Anything else you would add to that, Dr. Lyndaker? Okay.
No, I think that's complete.
Okay, thanks. And then, so just a high level, what does this process look like? Again, fairly similar to the traditional Medicare TCM. You've got the patient is getting discharged from a hospital or the ED setting. That generates a discharge alert through Healthy Connections, or if you live in another region, obviously whatever health information exchange you use, but for us, it's Healthy Connections. And then we actually take a next step with our ACO and our IPA. We know that our partners are set up to get notifications on discharge alerts for their patients, but we also get those alerts for any patients that are in our contracts. And so our team has developed a daily batch. We batch those together and we send them to our partners in sort of a curated form, so that we bring really the actionable pieces to our partners' attention. We have an internal application that sorts through all of those ADT messages and sort of cleans it up for our partners. And I'll get into that in the next slide. But once our partners have been alerted that patient X has just been discharged, then they go ahead and make that first contact within 4 business days. They make the second contact within 10 business days. So that was another thing. Medicare has 2 different codes you can use where you have that face-to-face within 7 or 14 business days. We collapse those into one service, so to speak, and ask our partners to have that contact within 10 business days. And there's a lot that's going into that process. As Dr. Lyndaker explained earlier, there's med reconciliation that's being done. You know, the team is looking at the patient's clinical needs, handling those referrals, but they're also doing that very critical SDH screening, coding, and referral piece as well. Then the partner can bill Medicaid for services otherwise rendered. So if they conduct an office visit, for instance, then they can go ahead and bill Medicaid for that. But they're also going to quote unquote bill NCI. They're going to keep track of each patient that they've done an mTCM with. And we have certain sort of predetermined periods of time where our partners batch those together and send them to us. We reimburse them accordingly. And then our team works on the data analysis. So now that we are, you know, more than 4 months kind of into this pilot, we're just now kind of at the point where we can start to do some data analysis. Obviously, you know, there's claims lag. In order to calculate 90-day post-discharge costs, you really need 90 days to elapse, plus, you know, some extra time to allow for claims. But literally what we've just started looking at this week is very promising, and we can see a measurable difference of the people that we know had a qualifying discharge. We can see a big difference between the ones that had this mTCM and the ones that didn't in terms of readmissions and costs. So I don't have exact figures to share with you for this call because we've just been working on it this week, but some exciting stuff, and we hope to see kind of how the rest of the data flows as we get into it. So as I mentioned, I think it's worth it to take a peek at the discharge notification process. It's sort of a technical part of the process, but it's incredibly important because if a partner doesn't know that their patient had a discharge, then they're not going to be able to do anything with it. So again, at sort of a high level, the HIE will generate a discharge notification when someone is discharged from, you know, the hospital, observation, ED, etc. We have an internal application. It's an internal software that our very talented data director created, and it sorts through those that flow, that big flow of notifications that we get every day, and it disqualifies some based on certain factors because they're not actionable. And it really just curates that list into one clean list. And then it imports it in an automated fashion into the kind of template that you see on the screen there. So we have some header information, and it gives the very high level, hey, reminder, this is what you need to do for the mTCM. And it tells them the patient name, date of birth, which contract they're part of, so which insurance they have, when were they discharged, where were they discharged from, and was it an inpatient or an ED discharge. We've added some more fields since then and some more little things to help better arm our partners with the information they need, but this is kind of the overall picture of what they receive. And then based on the partner's preference, we can send that through a fax or a secure email so that whichever team member or members are best appropriate to receive this and initiate the mTCM, they'll get that. Dr. Lyndaker, anything you would add on that piece, the notification piece?
No, I would say it's very similar to the other. The only issue obviously is when we're involving ER visits as well. So the volume is higher. Often the kind of the medical acuity is less. There's a little less of a draw in terms of the provider's attention, to be honest, because there's not often, these complex medical problems and treatment plans. It's often more on the the social determinants of health or some other kind of navigation issues that we're having. So I would say this is a much heavier multidisciplinary process in terms of care that involves care managers, certainly community-based organizations. It's I would say the at least as much responsibility and direction from the care manager as the providers. Whereas with the TCM visit, it's really loaded very heavily to the medical providers. So it's a little bit, it's just the nature of, the nature of the beast of sorts. And that, because it's multidisciplinary, it's new, the volume's higher, it's taking us a little while to kind of get it into our daily routine. And we're, as I suspect you all know, we're in a provider shortage area. So sometimes finding those office visit slots are not the easiest thing in the world. So it's a little bit of a headwind initially with this project, but I think especially if we get data that shows reduction in utilization in repeat ER visits, that's going to get the attention of providers and office managers as well.
Mm-hmm. Yeah, you bring up an excellent point and set of points, and one does speak to the prevalence of the ED utilization. We've seen so far that about 85% of the notifications that we're sending out are ED notifications, not inpatient, so it's definitely skewed more towards the ED side, which to me, reinforces why we're doing this. So I think initially some of our partners had a little bit of a problem with the fact that so many notifications were coming their way for patients who had an ED visit for something as simple as, I'm making things up, but strep throat, minor cuts, stitches, things like that, to them, this is not complicated enough to warrant a full-blown transitional care management service. But what we have kind of counseled them on and encourage them to do is, this is why this is needed, right? So in this case, the mTCM, sure, it's not going to be a heavily clinical focus. It's really going to be more of a focus on, hey, what time did this happen? What day of the week did this happen? And reminding them, We have same day appointments. You can call us 24/7. We've got, an on-call service. We can triage your needs. This is something that if you called us, probably wouldn't have risen to the level of an ED visit. We could have gotten you in that day. We could have, gotten you all ready to go. You wouldn't have had to wait in an ED room for 4 hours or whatnot. So it speaks to the fact that, there's still some potentially preventable ED visit usage of, for sure among this population, and that this is a tool to remind patients to call us as your primary care first. So that's been a good thing too. And then to Dr. Lyndaker's point as well, that this is uncovering sometimes not necessarily traditional clinical concerns, but social concerns as well. So, I didn't call you guys because I didn't think I could get to your office because Medicaid doesn't allow for same day transportation visits. But I knew I could hop in an ambulance and go to the ED, for instance. It's uncovering all of those things, and that, the patient can hopefully then be triaged and referred to the appropriate community-based organizations that can help with those things. Which brings us definitely to the next slide, which is taking a little bit closer of a look at the social determinant of health component to this. So as I mentioned earlier, it's really a 3-part process: screen, code, refer. The screen, we adapted that tool from the AAFP. I'll show that on the next slide. And we left it fairly open to our partners to administer this either during that first contact, maybe over the phone, in a guided process, or they could do it during the second contact. Again, whether that's handing the patient the piece of paper to fill out on their own, and then being reviewed shortly thereafter by the rooming nurse or care manager or whomever, or something that is a guided process in person. So that's been a little bit of a mini pilot within a pilot, is how is this best done? And I'll be honest, it's been a rocky road. Some patients don't like being asked these questions, and I'll show you some of the questions on the next slide. And some of our partners are pretty uncomfortable asking these questions. And so, we've just got to figure out how do we get there? What is the best way? What are some best practices to get at this level of detail? And one of our partners, when we were talking about this, kind of aptly commented, and I think they may even be on this call, or their team member maybe, but they commented to the effect of, well, remember when we started PHQ2s and PHQ9s? We didn't love that. We didn't like to ask those questions necessarily. They weren't comfortable with it at the beginning. And patients probably went through a phase of, why is my primary care doctor asking me these behavioral health related questions? People got used to it. And it's now sort of part of what we come to expect when we enter the doctor's office, is that, boy, they really do kind of think about my behavioral health as well. So it's going to be a culture shift, I think. But again, once the patient fills that out in whatever manner that looks like, then someone in the office needs to review and see if they have a positive screen, meaning they answer affirmative to any of the questions. We've developed a resource where we've grouped Z codes based on the type of questions that we've asked, so that we can point our care teams to say, okay, if a patient answered in this way to this question, here's a few Z codes to consider. Are these applicable to this patient? And for those on the call not familiar with Z codes, they're just basically a group of codes that capture social determinant of health circumstances or diagnoses. And they range from things such as, inadequate housing, homelessness, financial distress, interpersonal, interfamilial problems, lack of support system, poor nutrition, etc. And these Z codes can be incredibly helpful for us if we use them, as a medical system, because they're trackable. And right now, not a whole lot within EHRs lends well to discreetly capturing and tracking social determinant of health needs. So the Z codes actually ride along with the bill to the payer, and therefore you can track them through claims. So obviously, if you're managing a value-based contract, you can see those come through on the back end. And that's another thing that we, now that claims have been starting, now we need to take a look at our Z code billing volume to see where were we at baseline, how many codes were being coded before we embarked on this project, and how many are now being coded and captured, so that we can see what that looks like as well. And then the third piece is, okay, we've identified needs, now we need to do something about it. And here's where we provide our partners with a list of community resources that they can reference to help them conduct a closed loop referral. Again, this is a process that's just going to take some time for sure, but you've got to start somewhere. And this was, kind of our starting place. Those of you on the call, I'm just anticipating maybe some of your questions. And I'm anticipating some of you might be wondering, like, did we use a platform? There's a number of platforms out there that do this type of work, Unitas being one of them. We did not, simply because we sort of very deliberately chose to go a more simple, low-tech route to start, and a route that we can control. We can, update that resource inventory as we go, and make sure that our partners have an updated inventory. But it's not to say that we wouldn't go down that path at some point if that's where the data pointed us. So here's just a peek. It's just a screenshot of part of the screening tool that we use. And so you can see some of the questions related on this part to housing, food and nutrition and transportation. But we also ask about things like just utilities, their economic status. We ask about, their ability to understand kind of what the doctor is telling them and follow those medical instructions, as well as things about their personal safety. So how have things gone so far? In the first 4 months of our pilot, we've sent our partners over 1,700 notifications of our patients going to being discharged from the ED or inpatient settings. And you can see, again, that breakdown is very heavily on the ED side of things. Only 231 have been billed to NCI. So in other words, 231, which works out to be, I think, 13%, have actually had a fully complete successful mTCM. That actually is pretty much where we expected to be for this first few months. Again, if you go back to our Medicare slide, when we first started TCM, we were at 6% naturally. And I think we only got up to, 16% within, the first bit, and then 36%. So this is not totally surprising. And with the added factor of the SDH piece, we know that is, it's just something that we're kind of feeling it out, and each partner is figuring out how to do this. What you see on here are some of the kind of considerations and challenges that I would say that partners have noted to us to date. One being that in value-based contracts, Medicaid patients are automatically assigned to a primary care provider. And so that means that for any practice, there's people assigned to you that aren't actually your patient yet, because they don't have any primary care provider. But they have to be assigned to someone. And so some of our partners are getting notifications for patients who really aren't theirs, but this is a chance to try and engage them. And that's easier said than done, I recognize, but that's the hope, one of the hopes of this pilot. Perennial contact information challenges, for sure. Phone numbers, we can only give them what we know, whatever information we have. And the payer has, sometimes has the telephone numbers, but that's not always accurate. So there's always challenges there. Obviously, we live in a largely rural area. So, concerns around kind of a couple things. One is transportation. Although we've done our best to try and promote the use of telehealth for this service, there's still the rural consideration for those who would like to go in person and they can't do that because of transportation challenges. But also another kind of angle to the rural consideration is around the workforce. And as Dr. Lyndaker mentioned earlier, sometimes panels, and appointment availability are a little restricted. They might not have the bandwidth to take on, all of these appointments. That kind of speaks to a few of those others. Again, I shared some initial feedback around the social determinant of health elements. So when our partners fill out the billing sheet that we ask them to use to keep track of the mTCMs that they conduct, sometimes they add in some comments and some notes. And so we get in there sometimes things like patient became irate that we were asking them about their, housing status and refused to kind of participate in this service. And we've heard that anecdotally just in conversation with our partners as well. Although there's been a lot of, for every one of those events, I would say there's many more positive events, but it just speaks to, again, the reality that this is new for patients and it's new for our partners as well. So we've just got to figure out how do we ask these questions? What's the best way to do it? And then, as I spoke to a little bit earlier, this whole ED piece and the fact that a good number of those ED interactions are really for kind of very simple, not clinically complex things that potentially could have been handled in a primary care setting. And so that's an opportunity to have a call us first conversation. Dr. Lyndaker, I'll open it up to you. Any other comments that you would have on how mTCM has, our experiences so far?
Yeah, that was a really good summary. I think, I'm not sure where this is going. In terms of, I think we'll get a better routine in our offices. One thing I do potentially foresee is almost a two-tiered system, one of which primarily is managed by care manager, referrals to community-based organizations, kind of those often socially determinative health-driven things, and then maybe one more of a kind of typical medical model. And I think, we can each be kind of comfortable in those areas, and it might allow for increased mTCM visits, but not necessarily loading the clinical side in the future. I would see that as a potential kind of 2.0 version of this. And I think, the thing that I really like about closed loop order entry with CBOs is that it really forces two-way communication. And I think often the community-based organizations are frustrated with the primary care offices. And I know that the primary care offices get frustrated with the community-based organizations. And I think a lot of it is that we've lived in silos for a long time, and we probably talk different languages, or at least use different vocabulary. And we often don't have someone who is a liaison. So the hope would be that we can bridge that with our care managers, who for the most part, at least most of our practices, have someone in-house or a number of people in-house. So I think kind of a bigger goal in my mind is to start really leveraging the resources and quite honestly, the limited resources that we all experience to try to leverage that a little more directly with better communication. And I think the closed loop order, that way of handling it makes sense to me. But that's going to take us a little time as well, because it's a whole different area outside of what primary care offices have traditionally been involved with. So again, this is just kind of our first foray. Um, and I think it will take a little time and a little bit of traction before it catches on. But I think as the data comes in and people get more familiarity, we're hoping that we also get better ideas, better applications. And one thing I think we've been good about doing within the ACO and really within DISRIP as well is sharing kind of best practices and what's working among our partners. I think that's been one of the more valuable pieces as well. So I'm hoping that we can do that in addition.
Yes, thanks for that. And so where do we go from here? As I mentioned earlier, we definitely want to look at the data that comes through on, what are those post-discharge costs and readmission rates of those who get the mTCM versus those who do not. Maybe slicing and dicing that, looking at what's the difference between, the ED ones versus the inpatient ones. Is there any noticeable trends there? What does that look like? Monitoring our Z code billing and referrals to community-based organizations, taking a look at, what was the mTCM rates among the engaged patients versus unengaged patients, meaning those who are simply assigned to a partner but not actually active with them versus those who have established a relationship with that partner. I'm going to go out on a limb and say that the mTCM rates are probably much higher for the ones who are engaged versus not. But we want to take a look and see what that really looks like. And then from there, we want to do more of this, essentially talking with the community and the stakeholders around this project, what we're learning, what we can learn from others. We know we're not the only one, trying to get into the SDH space and really figuring out what that looks like for our patient population. And, kind of looking ahead to whatever is in the future and however we take this. But, this is a fairly narrow introduction of SDH screening. It's an important one. It's a critical one. It makes sense that we would prioritize SDH screening for, patients who have had some sort of inpatient or ED event. But, what could we do to expand from here? As we play with different strategies and figure out what works for our partners and for the patients they serve. When is this going to look more like, every patient being screened at least once a year? Because that's not currently what this project does. This screens patients for SDH at specific junctures that are triggered by episodic things. So how can we, expand that in the future as we move forward? And then finally, really our big dream in this pilot is, this really stems from the fact that Medicaid does not reimburse for TCM. And so how can we change that? If we do this pilot and if we can generate some ROI for that and a value proposition, and if we sort of extrapolate that out to the rest of the state, is there a way to get this to be a reimbursable Medicaid service? We would love that. And we think that, Medicaid patients deserve that. So that's a little health equity plug there. But that's kind of it in a nutshell. And I think we're ending at a fairly good time. I have been in presenter mode, so I haven't been able to see if any questions have come through. But this is our last slide here. This is Dr. Lyndaker and our emails. Feel free to reach out to us if you have any thoughts or want to continue the conversation. But I will, for right now, I think I'm going to end the slideshow so that I can go back to the full view and see if any questions have come in. Unless Dr. Lyndaker, if you have any parting thoughts.
Thank you, Joanna and Dr. Lyndaker. This was a great presentation. I do have a couple of questions that came in through the chat box that I'll read to you. The question is asked, is the TCM encounter multidisciplinary, or is the PCP doing all of the SDOH screenings, referral follow-up, coding, etc.?
Dr. Lyndaker, I could let you take that if you wanted. It's something you kind of spoke to a little bit.
Sure. So I would say it's certainly not team-based in terms of all at the same time. I think, different people within our practice will have their hands on it at different times. So often in our practice, for instance, our care manager gets notified of a discharge. If it's a kind of medical, like significant medical discharge, that will fall very quickly to the nurse. Although our care manager is also an RN, so that could go either way. And then, the SDH screen and MedRec usually is handled by our care manager. So she wears a couple different hats all at the same time. And then the scheduling would then, float to our front office staff and eventually provider on the schedule. What we haven't done enough to really get that flow loop well oiled and greased, because I think often what happens is it just can't stop at the provider, because the majority of the time it's the care manager who's likely going to have a much more significant role at influencing future behaviors and resourcing the patient with what they need or their family needs, to be well and healthy and hopefully utilize services less.
Thank you. And then another question that came through is asking about health home care management services, identifying that many of the clients would be eligible for care management, and asking if referrals are made to health homes as part of the workflow.
Yeah, that's a great question. And the short answer is yes. We made sure to include the health home agencies in our inventory. And there's been a little bit of re-education done with our primary care practices on, again, kind of what they can offer and how it works and whatnot. That was definitely, a focus during the district years, and want to make sure that our partners still know that that's something that, should be taken advantage of. It's a good resource in the community. So we haven't explicitly tracked any referrals to see like if there's been an uptake in health home referrals, but it's something that we were mindful of and wanted to make sure that partners knew of that as the resource too.
Thank you. And do we have any additional questions that anyone would like to put through the chat box? Please do so now. And if anyone thinks of any questions after the fact, Joanna and Dr. Lyndaker did provide their contact information, and the slide deck will be available. As we said on the Summit webpage by October 1st, you can also reach out to the AHI team directly for the contact information prior to that, if you do think of any questions. But I think at this time, since there's no further questions that have been added, we will end the session for today. Again, thank you, Joanna and Dr. Lyndaker, for presenting, and thank you for everyone who attended. And we will see you at the next presentation today at 2 o'clock for those of you who are planning to attend. Thank you.
Thanks for having us.
Thank you very much. Be well.
Thank you. Bye.